Good evening, everybody. We're going to go ahead and get started. Welcome tonight to our symposium on the burden of RSV in pediatric populations, the evidence for reshaping care and optimizing prophylaxis. My name is Kevin Ault, and I'm going to be the moderator this evening. My colleagues here are Dr. Sanchez and Dr. Munoz. I'll introduce them in a little more detail when it's their turn to talk. However, I was thinking this is a little bit like Jimmy Kimmel, me being Jimmy. You guys are an enthusiastic live audience. I have award-winning colleagues and guests with me. We're streaming this live to an audience at home, so thank you for coming. So thank you to Peerview for providing this session and Merck & Company providing the educational grant for this symposium. If you have not done so already, please do the pre-event survey. We're going to revisit that. That's my job as moderator to do that a little bit later. Look out for additional polling as well as questions that we're going to answer. And please submit those questions. I'm going to try to moderate that a little bit in my role tonight, and we'll try to answer them towards the end in our question and answer period. More slide here. Our goals for today are improve our understanding of RSV-related morbidity among infants and children. We were talking a little bit before we came up here. You guys are a little bit of a loaded audience because lots of you have expertise in these areas. Augment your knowledge of standard and emerging monoclonal antibody strategies for RSV and equip you with the skills you need to apply and adopt your local protocols for the prevention of RSV. And that is me. As I said, my name is Kevin Ault, and I'm an OBGYN at Western Michigan University Homer Stryker MD School of Medicine in Kalamazoo, Michigan. Okay, here are some cases that we're going to start with. So case number one is an infant that is born during the RSV season, November. Infant born at term with a heart murmur. Case number two is revolves around maternal immunization, maternal vaccination. A 29-year-old pregnant woman who's vaccinated against RSV at week 34, which was within the guidelines, and her infant is born 18 days later. So let's revisit the first case with some discussion. So for this infant born at term, how should healthcare team counsel expecting mothers and families about the RSV risk? We actually talked about this a little bit this afternoon. And Dr. Sanchez, do you want to make any comments?
Certainly. So this infant is a term baby, and really every single infant less than 8 months of age as they enter their first RSV season is at risk. So the counseling at this point, since the baby's born, and obviously the mother would not have received the RSV vaccine, is to discuss the problem of and the high medical burden of RSV infection, and recommend the passive immunization with nirsevimab.
Dr. Munoz, do you have anything you'd like to add to that?
How do you know she didn't receive the vaccine?
Well, we didn't write it into the case, so that's part of it.
That is true. That is true.
Well, I guess, just to talk about this, I think this is an important point, actually, because we do have the option of either maternal vaccination or passive monoclonal antibody to the baby. And a baby who is born in season at term is this baby. Probably the first question would be if mom has
Absolutely.
been, already immunized or not, because of course, the babies whose mother were not immunized can go ahead and receive the monoclonal antibodies, and this would be regardless of gestational age, as we know. And this baby has a heart murmur, and I think that that is one of the other questions. Does it even make a difference?
Are there any other OBGYNs besides me here? Okay, speaking for all OBGYNs everywhere, we need to make it clear to the pediatricians, my two colleagues are pediatricians, whether we vaccinated or not. And we have a lot of trouble locally doing that, and I don't think we have a slide about that. So we may talk about that a little bit in the Q&A. Are 2 doses of nirsevimab recommended?
I do want to comment, though, that if the mother received the RSV vaccine, the pre-F vaccine, the heart murmur does come into play, because if that were to be a severe congenital heart disease case, that is a circumstance where the baby would receive nirsevimab, even if the mother received the pre-F vaccine at the appropriate time.
We do have a slide about that later. I remember that slide. So. Okay, in the interest of time, I'm going to move on here. So this is the maternal immunization case. So is this a higher risk scenario? She was vaccinated at week 34, which is right in the middle of the range, and then delivered at almost 37 weeks, 18 days later. What do you think, pediatricians?
Well, I can start with this one. So of course, again, we have the options. And I think this is really just a reminder of the fact that we do have a particular period in time in pregnancy where we can administer the vaccine to the mother. And again, it's wonderful to share the podium with Kevin, who is an OBGYN, and will confirm that at least in the United States, OBGYNs are very much in favor of giving vaccine to pregnant women. And so in this case, she was vaccinated so that her baby would be protected at week 34, which is within that range, 32 to 36 weeks. Now, the baby was born a couple of weeks later, but I think what's relevant here is to keep in mind that if you are vaccinated in pregnancy, you do need about 2 weeks to have a very good immune response that will be sufficient to pass those antibodies to the baby. It's 2 factors. It's how much antibody is made by the mother, and then the time that you have to transfer that antibody through the placenta. But generally speaking, 18 days later should be enough for this baby to have received sufficient antibodies from the mother. So this baby is now born at about 36 weeks, depending on when exactly at the 34-week time came. So maybe the baby could still be a little bit premature, but I think that, again, given the timing, I would think that this is an appropriate vaccination and that this baby does not need monoclonal antibody. What do you think, Dr. Sanchez?
No, I agree with you, but as we'll discuss later, there are certain circumstances where even if the mother received the pre-F vaccine, and we don't know if she's HIV infected, even whether or not she's virologically suppressed or not, but if she were to be HIV infected or immunocompromised, if she received the vaccine, that baby would still need the, at least our current recommendations are that we cannot rely that the mother did respond appropriately to the vaccine, and that baby would receive nirsevimab on top of that. So there are some circumstances where the baby should receive nirsevimab despite the mother having received the vaccination, even if the vaccine was given 14 or more days before delivery.
A bunch of you have asked questions, they're variations on what he just said. So I'm going to use my prerogative as the moderator and move on and not answer that fourth one because you guys are all asking us that question. Okay, so we've decided that immunoprophylaxis is recommended, and the heart murmur is a little twist for case 1. And then for case 2, maternal vaccination is the standard of care for this. She received it right in the middle of the range, and this is pretty much what you just said. Nirsevimab is required unless there's other criteria. Okay, I'm going to turn this over to Dr. Sanchez, who's a professor of pediatrics at Nationwide Children's Hospital at The Ohio State University College of Medicine in neonatology and pediatric disease both. And you won an award this afternoon, again, keeping with the Jimmy Kimmel theme. I was hosting the Oscars. We'd be talking about, tell us about your award.
Well, I was awarded the Walter Hughes Award for Lifetime Achievement in Pediatric Infectious Disease. And so, Thank you.
Just a few hours.
Thank you. It just shows that I have a lot of good friends. Thank you, thank you. Okay, so today we're going to speak about the burden of RSV, which is, as you all know, substantial. So on a global basis, the estimate of, RSV is really a major cause of morbidity and even mortality among infants, again, worldwide. 33 million new episodes of RSV-associated acute lower respiratory infections are estimated to occur on an annual basis in the world. And along with that, 3.6 million RSV-associated hospital admissions, and importantly, over 100,000 deaths attributed to RSV on a global scale. In terms of RSV attributable mortality on a global scale, 1 in every 50 deaths in children aged 0 to 6 months, 1 in every 28 deaths in children aged 28 days to 6 months, and for every RSV-associated acute lower respiratory tract infection that results in an in-hospital death, there's approximately 3 more deaths attributable to RSV in the community. The medical burden and societal burden of RSV is immense. And we talk a lot about RSV hospitalization, which is really a major endpoint and something that we obviously want to prevent. But what you can see on this slide here, this is the months on the x-axis and the rate per 100,000 of medically attended RSV infections in the y-axis. And you can see that when we talk about RSV hospitalization here in the purple, that's just the tip of the iceberg. You can see in red the emergency visits, and in green the number of outpatient clinic visits that are attributable secondary to RSV infection. So when we talk today about prevention and efficacy of these agents against RSV hospitalization, we really need to look beyond just that, beyond the hospitalization, and look at the medically attended lower respiratory tract infections, which was a major focus of all the studies of nirsevimab and as well as the maternal vaccine. So actually, RSV bronchiolitis is the leading cause of infant hospitalization and accounts for about 10% of total infant hospitalizations in the United States and globally. So this slide here shows how RSV hospitalizations compare to hospitalizations due to COVID and due to influenza. And you can see on the red are the hospitalizations, the rate per 100,000 populations in children up to 4 years of age. And you can see here is the COVID is in the red, then here is the influenza. And actually, RSV hospitalizations nearly equal those for all of those combined. So really, it's a huge, huge burden that we are extremely, extremely excited to finally have some prophylactic measures to really decrease this rate. Because most infants, about 68% of them, are infected in the first year of age, and virtually all of them are infected by 2 years. 2 to 3% of young infants will be hospitalized for RSV. It's a common cause of lower respiratory tract infection, and the highest RSV hospitalization rates occur in the first months of life, and the risk decreases with increasing age in early childhood, but as you saw, in the first 4 years of age, it still is a major cause of hospitalization. And very, very importantly, 79% of children hospitalized with RSV who are less than 2 years of age have absolutely no underlying conditions. So the major risk factor of an infant is the fact that he is less than 8 months of age as they enter or during the RSV season. It's not all of the other risk factors we talked about with our previous monoclonal, such polyvisomab. So let's review some preventive strategies. So certainly there are some non-pharmacologic strategies that can be utilized. Being a neonatologist and actually a pediatrician, I really focus on the benefits of maternal breastfeeding and maternal milk. And in some studies, exclusive breastfeeding for greater than 4 to 6 months of age significantly lowered RSV hospitalization, hospital length of stay, the need for supplemental oxygen, and even admission to intensive care units. So this is really important. God knew what he was doing when he gave mothers milk, and let's utilize it, and let's utilize it wisely. Non-breastfeeding increased the risk for severe RSV-associated lower respiratory tract infections and RSV-related hospitalization. And this, on top of all of this, we also need to tell these parents that they need to prevent the exposure of their young infant to others who possibly have RSV or any other respiratory viral or any other infection. So when I counsel my preemies and my newborns who leave the NICU, I tell these parents, hibernate for a little while, because this baby, this neonate, has no business going going shopping, doesn't have any business going to the food store, to Kroger's, to any place else. Hibernate, stay with your child, breastfeed your child, and things will be good. However, we also know that exposures do occur, even as much as we don't want them to occur, especially if they have siblings in the household. And so we know that there's two prophylactic strategies, and we've mentioned already the pre-fusion RSV vaccine, as well as the nirsevimab, the monoclonal antibody. We know, and I'm not really going to discuss this much, that the pre-F RSV vaccine is now recommended for elderly, for those who are 75 years of age and older, and that's not me, not yet, and for those 60 to 64 who have underlying risk factors. But let's focus on the infants and mothers. So all infants whose mothers did not receive RSV vaccine during pregnancy, as well as some children, high-risk children, ages 8 to 19 months, who are at increased risk for severe RSV disease, should receive nirsevimab. And in general, in the United States, the RSV season really starts in November to March, but we want to anticipate it and start giving it before the RSV season, which is in October. So October through March is the time when we, in general, give nirsevimab. There are some places, such as southern Florida, Hawaii, for instance, where they see RSV year-round, and certainly other strategies are called for. So we mentioned also that the RSV prefusion vaccine should be given to all pregnant women during weeks 32 to 36 weeks of their pregnancy. It is a seasonal vaccine, and again, at least in most places in the United States, it's given from September through January. So ACOG, as Dr. Ault here mentioned, recommends RSV vaccination from September to January for women 32 to 36 weeks. RSV vaccination during pregnancy is a safe and effective way to prevent severe lower respiratory tract infections in infants. Now, we know the experience with palivizumab, the previous monoclonal antibody. It was indicated for the prevention of serious lower respiratory tract infections due to RSV in pediatric patients. Based on the most recent 2014 AAP statement, it was only given to infants and high-risk children, and only infants who had significant risk factors such as being prematurity less than 29 weeks or bronchopulmonary dysplasia less than 32 weeks gestation. There was no role in otherwise healthy infants. Yet, as I mentioned, the vast majority of these RSV hospitalizations occur in these children. And on top of that, palivizumab was expensive and pre-authorization required prior to administration. It really was a pain in the neck to administer. And so we are extremely excited as a community, a pediatric community, to have now nirsevimab for all children, or for all infants and high-risk children. So nirsevimab is a long-acting monoclonal antibody. One dose of nirsevimab will last at least 150 days, i.e. will last the entire RSV season. You can see here, nirsevimab here, it binds to the so the fusion protein of the virus, of RSV, exists in two configurations. There's the pre-fusion configuration, and then once it attaches to the host cell, it becomes the post-fusion configuration. And luckily, nirsevimab was developed against the pre-fusion configuration, therefore blocking the conformational shift to the post-fusion and preventing the fusion of the viral and cellular membranes. So this is really critical, because if it had been developed against the post-fusion, it would not have worked. So the trials that have been done that have shown the efficacy of nirsevimab, and this one here was a phase 3 so-called MELODY trial. The MELODY trial enrolled late preterm infants, 35 weeks gestational age and greater, as well as full-term infants. And this was a randomized placebo-controlled trial. And the efficacy against medically attended RSV-associated lower respiratory tract infections was 76.4%. The efficacy was of 76.8% was seen against hospitalization for RSV-associated lower respiratory tract infection, and an efficacy of 78.6% against very severe medically attended RSV-associated lower respiratory tract infections. So really, it's an exciting time. Now, subsequently, there was the so-called HARMONY trial, and this was a pragmatic trial that was performed in France, Germany, and the United Kingdom. And they randomized these infants, some of them were preterm, they were 29 weeks gestational age or greater, and also term as up to term, and they were less than 12 months of age. They were randomized to standard care, which in these countries there was no provision of palivizumab to these children, so it was standard care, was no prophylaxis versus nirsevimab. In this trial, nirsevimab, the efficacy against RSV hospitalization was 83%, and the efficacy against very severe RSV hospitalization was 75%. So when the CDC, the Advisory Committee on Immunization Practices, reviewed the data on nirsevimab, and actually I was on the committee that reviewed it, and I'm very proud of the fact that I voted for both not only nirsevimab, but also for the RSV prefusion vaccine. But when they did the efficacy assessments against medically attended RSV lower respiratory tract infections was 79%, RSV lower respiratory tract infection with hospitalization was 80.6%, and RSV lower respiratory tract infection with ICU admission was 90%. I mean, these are great numbers. There were no deaths attributable to nirsevimab and to RSV during these trials, so it was not able to be assessed. And giving nirsevimab and reducing RSV hospitalization and disease was not associated with an increase in other viral infections. So what is the real world? Now it's been approved, it's out there, we can get it, we can give it, these babies can receive it. So what is the real world experience with nirsevimab? So the CDC has 7 pediatric academic centers that belong to the new vaccine surveillance network. And with preliminary data, they showed a 90% effectiveness of nirsevimab, very similar to the randomized trials. And in Spain, in certain hospitals in Valencia, Murcia, and Valladolid, anywhere between 70 to 84% effectiveness. And in another area of Spain was 88% effectiveness. You see Spain a lot because Spain has done a fantastic job at getting nirsevimab into these babies. There has been high adherence, compliance with accepting nirsevimab, and you can see that the results are really amazing. In Luxembourg, there was 84% coverage in maternity wards, and they showed that it decreased RSV hospitalization and pediatric intensive care admissions in infants who were less than 6 months of age. And more recently, this past July, there was a study from France that showed 83% effectiveness, and in Galicia, another region in Spain, was 82% effectiveness. I just want to highlight a late breaker abstract that will be presented tomorrow, in which the Chilean experience will be discussed. And I just want to add, I don't have the exact numbers, I have not seen the abstract, but word of mouth is that they had very high uptake of the nirsevimab in their infant population, and that the effectiveness really was quite high, I believe it's about 90%. So what is the guidance on the administration and the use of nirsevimab? So all infants younger than 8 months of age, born during or entering their first RSV season, should receive nirsevimab. Even healthy, no other risk factor. And infants and children age 8 through 19 months of age who are at increased risk of severe RSV disease and who are entering their second RSV season. Important to say that mothers who received the pre-F RSV vaccine in one pregnancy, it is not recommended for them to receive it again in a subsequent pregnancy. At least in adults, RSV antibodies following the vaccine seem to last at least 3 years, but we don't have safety and immunogenicity data in these pregnant women, and so beyond the first time that they receive it and with their infants. So there is no recommendation to provide further doses at this time. A future pregnancy, that baby should get nirsevimab. And so how about who is at high risk in a second season? So these are children who are aged 8 to 19 months of age, and they have to be that age at the day of nirsevimab administration. So these children have chronic lung disease of prematurity and are receiving medical support during the 6-month period before the start of the RSV season. If they're severely immunocompromised, or if they have more complicated cystic fibrosis disease, as you can see here. Also, RSV disease is almost endemic in the American Indian and Alaska Native children, and they should not only receive the nirsevimab or prophylaxis in the first season, but also in the second season as well. So other practical considerations to sum this up: infants with prolonged birth hospitalization who are less than 12 months of age and are being discharged after 8 months of age, but less than 12 months of age, who are receiving oxygen, they should also receive nirsevimab at the time of discharge. We do not recommend administering it during the NICU stay. We have other infection control preventive strategies to prevent RSV in our hospitalized children. Additional dose of nirsevimab should be given after surgery or ECMO during the RSV season if they're still age eligible, because the ECMO and bypass surgery takes out their pre-existing antibodies. Our children who have received nirsevimab should not receive palivizumab in the RSV season. There's no need. Nirsevimab is going to last through the entire RSV season. However, if for some reason that baby received palivizumab, which I don't see any reason other than shortage, then that baby can receive nirsevimab, so you don't have to complete the 5 doses of the nirsevimab, of the palivizumab, sorry. And so eligible infants may receive nirsevimab after an RSV infection, and nirsevimab can be co-administered with routine childhood vaccines. Remember, nirsevimab is not a vaccine, and in this age of a lot of vaccine hesitancy, we need to make that clear to these parents. And most common AEs included just rash and injection site reactions. It really is a safe modality. So with that, I'm going to hand over to Dr. Ault.
Well, let's talk about this a little bit, because this is something that I mentioned. Do you want me to go over this, or do you want?
Okay, let me finish here. I'm sorry.
Yeah. I think we gave away this slide.
Okay, so principles for using maternal pre-F vaccination and nirsevimab against RSV. So only select infants should receive nirsevimab after maternal vaccination. And these are infants of immunocompromised mothers, like we mentioned, infants of mothers with conditions associated with reduced transplacental antibody transfer, such as HIV-infected mothers, infants who are post-cardiopulmonary bypass and ECMO, and then infants with hemodynamically significant congenital heart disease, intensive care admission from birth and requiring oxygen at the time of discharge. So what about the coverage of nirsevimab and maternal vaccine? Overall, these are data from the Morbidity and Mortality Weekly Report from CDC. And so overall, about maternal vaccine or receipt of nirsevimab was seen in 55.8% in a survey that was performed by these investigators. So 44.6 received nirsevimab, the infant received nirsevimab only. 32.6, the mother was the one who received the prophylactic measure for the baby. So overall, 55.8%. But what is important is that almost half of young infants were not protected from RSV last season because they didn't get RSV antibodies and their mother did not get maternal vaccination. We still have a lot of work to do to get these prophylactic preventive strategies into these mothers and their infants. Thank you. Now it is your turn.
Now it is my turn. So, I get confused. Okay, I'm going to give all of you a chance to rethink your choice. So, when should antibody prophylaxis for RSV be recommended when maternal vaccination has not been used? I requested Hotel California to be played during that, and I was told that's a copyright violation. Okay. Do you want to answer this, since this is one of your big take-home points, Dr. Sanchez?
No, absolutely. The majority were correct.
Yeah.
That for any infant born during the season, regardless of risk, I think that's really what we have to emphasize, that every single baby, every single infant less than 8 months of age who are entering their first RSV season, they are at risk for severe disease. Remember, 80% of hospitalized infants have no underlying risk factors.
I think our pediatricians in a relatively rural part of America in Western Michigan say the same things that you are saying, but you know, you kind of have to rearrange your thinking because of the shortage from last year. So maybe we'll talk about that if we have a little time at the end.
Hopefully we have no shortage this year. So far, we
Right.
don't.
This is, again, a scenario that you've already answered. We're going to do a pre and post. Reconsider this scenario. A 29-year-old pregnant woman is vaccinated against RSV, week 34, and her infant is born 18 days later during RSV season. What would be your next step to ensure adequate protection against RSV? You guys are good. So yeah, I think 2 is the correct answer there. No additional prophylaxis is needed unless post-birth complications or maternal factors support further prevention. Are we all agreed on that? All 3 of us? Everybody out there is agreed, obviously.
Absolutely. I think the important thing is that at least in the United States, we have gone with one or the other, but there are some certain circumstances where the maternal one is not sufficient for the baby. And so in those instances, then, as I mentioned earlier, both strategies should be utilized.
And as I said previously, since I'm on that slide, I'll finish out this section by saying, a lot of you are asking questions along that line, so we're going to talk about that in the Q&A. Okay. Case number 3 is an infant born prematurely at 26 weeks during the RSV season, so January 2024. No maternal vaccination, because she wouldn't be far enough along. No immunoprophylaxis given in the hospital. Infant growing and developing well, but chronic oxygen requirements since birth, nasal cannula at night, and discharged home in November 2024. Okay, should immunoprophylaxis have been administered after birth? We only have a few minutes. I know you two disagree about this. So Let's let Dr. Munoz go first. So switch it around a little. So
Okay, here's the baby that was born in the middle of our RSV season in January 2024. Yes, the baby was premature, 26 weeks. And obviously, the mom would not have been able to get vaccinated because you can't start until 32 weeks. But, the question is, we have the option to administer nirsevimab from birth, and we say regardless of gestational age and regardless of any underlying condition. So I think this is interesting because if you apply that, this baby should have received nirsevimab at birth, right? He's saying no. But, and the thing is, this is actually something that I think is important to think about as we are implementing a new strategy, right? Because that's what the recommendation says, but I also heard, Dr. Sanchez say, do not administer in the NICU, administer it before discharge for neonates. And so it kind of contradicts a little bit what I just said in terms of the recommendation, give it to everybody regardless of gestational age. Because, the issue is, what is the risk, right? So clearly a premature baby, especially 26 weeks, is going to be at risk for RSV complications. And the question is that risk only when they leave the hospital, or is that risk as they are, growing and feeding and trying to survive that prematurity? And my take is that RSV is very contagious, and we still don't have control of RSV. So do we see nosocomial RSV? Yes, we do. Maybe I haven't been in the NICU that much. I do a lot of transplant ID, but I do see, my very immunocompromised patients and chronic lung and chronic heart patients that have to stay in the hospital that I would like to give nirsevimab if they meet criteria. And so I think that where we are having a little bit of a discussion here with Dr. Sanchez is, this baby did not receive anything. And then, of course, now they're going home. We're coming into the RSV season. Yes, I would definitely give this baby nirsevimab and immunoprophylaxis at this time, right? So there's no question about that. And I would give it before they leave the hospital, as it's indicated right now, because they're going into their second season. This baby is older right now, but they still meet criteria because they're still under 19 months, actually, which is the upper age. But so, I think we wanted to have this discussion to see, what do you do about that baby being born in the middle of the season, even this coming season, who is premature, that will be staying in the hospital?
So we do agree that this baby should receive nirsevimab immunoprophylaxis at the time of discharge, even though he is older than 8 months of age, and even though, and I think this was one of the caveats that we mentioned, because as more and more premature babies are surviving and are developing BPD or other complications of prematurity, and they go home in the middle of the RSV season, yet they're over 8 months of age. And so this is a condition. This is one reason why we've recommended that infants who have a prolonged preterm infants who have prolonged hospitalization, and they prolonged hospitalization from birth hospitalization, and they go home after 8 months of age in the middle of the RSV season, that they should receive nirsevimab, even though they are not if they haven't received it previously, and they meet certain high-risk criteria. And so that we agree with. However, I would not have given this baby at 26 weeks gestation when he was born. First of all, we have no pharmacokinetic data on the dose that should be given to premature babies. All the data we have are babies who were given a few days before discharge. And so that's one thing. So will the future allow us and do studies that maybe we can do something like this in these premature babies? Yes, I think that may be considered, and I don't know if those studies are ongoing or even thought of, but I think certainly that might be. However, we have to...
2 minutes and 28 seconds.
Okay.
So,
we have to prevent RSV infection in our NICUs, and we have preventive strategies that can do it. We shouldn't not be allowing parents who are sick, siblings who are sick, healthcare workers who are sick to be touching our babies. And we are very effective at preventing it. There's no question that there's RSV outbreaks. There's no question that it's a huge financial as well as a medical burden. But we need to use our infection control policies to prevent that occurrence. And then dose that baby a few days before he goes home.
Speaking of future developments, what is the rationale for developing newer antibiotic prophylaxis for pediatric RSV? Assuming availability, would fixed-dose clorozumab, am I saying that right?
Clorozumab.
I should have had a glass of wine with dinner. I probably could have said it a little better. A useful strategy. And would care planning change given its availability? We only got about 2 minutes to answer this, and Dr. Munoz is going to talk about some of the underlying data. Does that change what you just said if this was available as an option based on what we know today?
Are you asking me or Dr. Sanchez?
He looks lost in thought, so maybe we should go with you first.
Well, what I would say is that I think this is, again, a point of contention because I think we need to still learn and optimize how we use our monoclonal antibodies and how we best protect the infants because we know these are efficacious interventions. And so we've heard shortages as well, and as part of the discussion, I think this is one of the reasons we didn't achieve such high coverage, in addition to the fact that, of course, we started late in the season in the U.S. last year, but we did start, and it was great that we covered half of the infant birth cohort. But I think that having additional options for monoclonal antibodies is going to be very helpful. And this is part of what we are sharing with you this evening in a little bit.
You have anything to add to that?
No, exactly. We want options, and we have the option of a maternal vaccine, we have the option of nirsevimab, but we want other strategies. And in all honesty, I hope that the price comes down with competition.
You compare to the flu vaccine we give pregnant women, the maternal vaccine is hideously expensive, so we could talk about that all night probably. Okay, so in this case, immunoprophylaxis in the hospital is not recommended, but we have differences of opinions. I bet there are differences of opinions out there among you too. Immunoprophylaxis is recommended after discharge. Clozrovimab may be a new option with convenient non-weight-based dosing. And I'm going to introduce our other colleague, Dr. Munoz, who's the Associate Professor of Pediatrics, Infectious Disease, Molecular Virology, and Microbiology at Baylor College of Medicine and also at Texas Children's Hospital.
Wonderful. So thank you. I promise it'll be short because we do want more time for Q&A. And I start with this slide that many of you have seen before. Dr. Sanchez already talked about the pre and the post-fusion conformations of the pre-F protein, of the F protein. And this is just to summarize a little bit what we've been saying. So we have here at the bottom palivizumab, which is well known, was actually present in both the pre and the post-fusion conformations and targeting site 2 of the F protein. Nirsevimab, as we have mentioned, targets site 0, which is present only in the prefusion. And you see that between these two, there's a gradient of neutralizing potency of the antibodies depending on the target, with the highest neutralizing potency for site 0. So it's great. We have a very active, very potent monoclonal antibody. What we wanted to introduce today is also clozrovimab, which is also a monoclonal antibody. And you see that it targets site 4. And this is here in the purple, and it's present in both the pre and the post-fusion conformations, similar to palivizumab. And so we are going to focus the rest of the discussion a little bit on this new monoclonal antibody. I do have to mention, because we talked about maternal vaccine targets include all of the epitopes, all of these, because it's against the entire pre-F protein. Now, if you just wanted, again, we're just going to give you a brief overview because there's limited data that is publicly available on clozrovimab, but we've been hearing about a new monoclonal antibody coming up in the near future. So this is a fully human IgG1 antibody that also has an extended half-life, and it also has the potential of providing protection for the entire RSV season. It does have that site 4 as its target, as you have seen, and it's an epitope that is actually, as we know, very highly conserved. It targets both RSV-A and RSV-B, and it's very much likely to work very well regardless of the type. It does have amino acid substitutions, to the Fc domain, similar to nirsevimab, which allow it to be having an extended half-life. And it has been evaluated in adult clinical trials in a phase 1, mainly to demonstrate that it was actually well tolerated. This is a very brief summary, with a safety profile similar to placebo, meaning, it didn't really have any substantial adverse events. In adults, the half-life that is reported is 73 to 88 days. And one thing that is quite interesting about this particular monoclonal antibody is that it has been found in high concentrations in the nasal secretions, nasal tissue, with good distribution in this area after an intramuscular injection. And this is, of course, very important because this is the site of entry, as we know, for RSV. In addition to that, there was a human challenge study that was done where you could actually demonstrate that the serum neutralizing antibody titers that you have with the injection actually correlate with the efficacy that is seen by looking at the concentration of the virus in the nasal epithelium. So we use these serum neutralizing antibodies as a surrogate, if you will, or as a measure to assess the immune response. So this monoclonal antibody, clesrovimab, is currently in development. It's meant to also target infants in their first RSV season, and you see the clinical trials have included healthy preterm 29 to 35 weekers, term infants, and this is our studies that are done compared to placebo, similar to the nirsevimab. But also, of course, the high-risk infants, and they're the same groups basically there, the chronic lung disease, chronic heart disease, the premature babies, and some other risk factors like cystic fibrosis, neuromuscular disease, Down syndrome, and also the high-risk populations. But this is, again, for these high-risk groups for protection against RSV, both in their first and second season. And in these cases, it's compared to many times palivizumab, because this is what they would get otherwise. And again, single dose, as we can see, based on an intramuscular injection with a single dose that is given. So I will share with you what is available. This is actually partly published and partly presented also at RSVNet by Professor Shabir Mahdi, who was one of the main investigators. And this is just to give you a sense of what we know right now in a phase 1b to 2a study looking at these preterm babies, 29 to 35 weeks, but also at full-term infants. And you see that it's the same age range. In this case, the age of administration from 2 weeks to 8 months of age. And it's a small study. This is phase 1-2, just to look at mainly pharmacokinetics and look at safety profile. You see that 183 infants were enrolled, and you see at the top, I'm showing you here that there were different dosages that were tested from 20 to 100 milligrams, and it was either the clesrovimab versus a placebo. While in the full-term infants, it was a 100 milligram dose versus a placebo. You see that the goals of this study, as I mentioned, is to look at PK, specifically looking at up to 150 days, looking at serum neutralizing antibodies, as we mentioned, as an indicator of protection up to a year. There are also another important point, which is looked at for these monoclonal antibodies, is whether there could be antibodies against the drug itself, against the antibody, and that is something that is monitored for monoclonals in general. And of course, safety and potentially some initial assessment of efficacy. So as presented, this data, as you can see here, in terms of safety, you see here, again, the different dosages up to preterm and then the full term with the groups that were compared to placebo. And in general, what you can see here is that the drug is very well tolerated with no significant difference in, numbers of adverse events. So things that would be reported would be similar in the placebo and the treatment groups. And certainly no serious adverse events or any treatment-related adverse events, mortality or any discontinuations. There were also no concerns for allergic reactions in this case. So very similar, very, very good safety profile. Now, this is one of the figures that was presented again at ResVNet. Maybe some of you were there. This is just to show you that given the different dosages that were administered, there was a dose-dependent increase in serum neutralizing antibodies, as you would expect. Here in gray, you have the placebo group from day 1 to 150 to 365, and there's no increase. While for the different dosages that were given, you see a very nice increase up to 150 days, and basically 16 to 23-fold increases in the serum neutralizing antibodies in the higher dose, which is the 100 milligrams. And this is true for both, preterm and the full-term infants. These are the two that you see here at the top. So basically, that 100 milligram dose seems to be really working well, regardless of the size of the baby. And when you look at the PK, just again, trying to have a good sense of how the antibody actually comes down over time, you see again, this is the lower dose here, but with the higher doses, we have again at the top the 100 milligrams for the preterm in the orange, and then the 100 milligram for the full term in the blue. And you see basically the similar trend as you would expect with IgG. A similar rate of elimination is observed here up to 150 days with pretty high concentrations remaining for the high dose groups. So they were able to calculate a half-life. And this is a summary. Here you have at the top the preterm, and then at the bottom the full-term babies with the different dosages. As you would expect, the half-life is very much the same, regardless of the dose, because it's an elimination time. And you see that in infants, it was estimated to be on average about 45 days. So here you have from 45 to about 48 days. So that's good in terms of the data. What about these antibodies to the drug? And so you see here the proportion that had developed some antibodies, and it was varied, about 13% in the first 150 days and 22% later. But when you look at the half-life, it didn't really get affected by the presence of those antibodies, or the PK was not affected. So obviously this was not a study to look at efficacy whatsoever because it was a very small study. Nevertheless, you can see that there were some outcomes that were investigated, acute respiratory infection and also hospitalization. And you see the combined group of all of the dosages for the babies, the preterm babies, and then the 100 milligram in the full term. And in general, again, we can't say really anything at this point because this is just a quick look. But you see that the hospitalization, which would be probably the more severe, it looked pretty good. So I'm not going to say that we know efficacy based on this study yet, but the trend is looking pretty good. What I would like to say is that we will have a presentation at this meeting that I'm just giving you a preview here because it will be something that you will get to hear all the details on the healthy infant study. There's a phase 2/3 clinical trial that looked at healthy babies. You see now again looking at safety and efficacy. More than 3,600 babies receiving placebo versus a single dose of clesrovimab, and then looking at, as we expect, RSV-associated medically attended lower respiratory tract illness, as well as a number of safety endpoints. And this is what we heard about just this summer in July as a preview again, indicating that there would be good data coming out. So tomorrow, this is the time, 2 p.m. Please don't miss it. ID Week, late breaker, and this is going to be where you get to hear all the details. And the second study that is also being presented here is a study in the higher risk groups. So this would be a study looking at 1,000 infants with those increased risks for severe disease, again, compared in this case to palivizumab versus clesrovimab at a single dose. And you see, again, primary endpoints looking at safety, but also looking at, again, in this case, medically associated lower respiratory tract illness, hospitalization, and other outcomes. This study is looking at both season 1 and season 2 for these high-risk babies, and this is also going to be presented tomorrow at 2:21 p.m. So I will not give you anything because I don't have any more data to share with you, but we did want to give you these updates so that we can have a discussion and anybody can bring it up. So I'll stop there. Thank you.
So before we get into the follow-up questions here, I think some of the authors of all these late breakers that we're mentioning are here tonight. Did I see some of them? Can you raise your hand if you're brave? And we will not call you to the podium, but somebody will come and nobody's brave enough to raise their hand. Okay, so, but support our colleagues by coming to their sessions tomorrow afternoon. So. You're managing an infant born prematurely at 26 weeks during the RSV season, January 2024. No immunoprophylaxis was administered. This infant has continued to receive oxygen by nasal cannula and is now entering his second RSV season after discharge, November 2024. What would you now recommend for this patient after our discussion? Yeah, most of us answered the same on the pre and post here, and we agree, the three of us agree, I think.
Absolutely.
Yeah, so we are in agreement for that one. So we can argue more about the hospitalization later. So rethink your choice about this one as well. Which statement reflects the current evidence on the dosing strategies with the emerging antibody clesrovimab in the RSV setting? Okay.
Good job, Flor.
And you'll hear more about this tomorrow, as I said. So, okay, I'm going to jump into some questions. There's no way we're going to get to all of these, but a lot of them are similar. So, there are several questions along this lines. Is there any role still for pezlivimab in our current environment?
So we really need to think about going away completely from palivizumab. Now, and Flor may discuss the immunocompromised host. Nirsevimab, at least as of today, we do not give it intravenously, and certainly hasn't been studied for RSV disease either. But in immunocompromised hosts, if you are treating, the bone marrow transplant patient, you want to give an antibody to ameliorate the disease, then palivizumab there would be the one to use. But otherwise, without shortage, there really is no reason to not give nirsevimab. I think it is really important that we talk to our hospital administrators, our pharmacy, our pediatricians, the family practice people, because nirsevimab is the way to go.
I'll just say, again, we have options, right? And it's great to have more than one monoclonal antibody. I think it's going to be great. This season, obviously, we don't have clesrovimab, but the data is looking good, and again, we'll hear more information. And hopefully next year, we have 2 monoclonal antibodies that can be given as a single dose for the entire season. But I think it depends, right? Because I know there are many places that don't even have the option yet for nirsevimab. And so Pali is still playing a role in some places where you do need to cover your high-risk babies. I think that I agree 100%. Eventually, it'll come off, right? It won't be an option anymore because it makes sense. Single dose, cost-effective, highly efficacious, safe, and that will have more than one monoclonal to give. So it'll eventually phase out.
Yeah, and remember that if you do give palivizumab, you're only giving it to the previously recommended high-risk criteria, and so we're missing our normal full-term infants are missing that benefit. Just get rid of it.
So this question may have been planted by the PEDS ID fellows at Texas Children's. What incidence or prevalence of nosocomial RSV in the NICU would Dr. Sanchez sanction delivery of inpatient nirsevimab?
I think that if it's not even, I'm not even going to talk about the rate or the prevalence or anything. It should not occur. And if it is occurring, you need to look at your infection control practices and fix them immediately. So, and that's it.
We have a moment for counter discussion if somebody would like to add anything. It's one of the three of us, I guess.
Well, again, it contradicts the current recommendation. I think it's interesting, right? I mean, I don't know what people think, but I think it's a little tricky, right? Because the cost. Maybe what I would like to say is talking about palivizumab. Unfortunately, palivizumab definitely was not recommended that way, but there was a cost issue. There was many doses given. There was, a lot of administrative work to do. And so if that's true for NICU, and it's no longer the case for nirsevimab, then that argument is not there versus. So the cost of having a baby stay or having complications from RSV, if they just happen to get RSV in the hospital, is going to be so much higher than what it was before. But we're not going to go into a lot of detail because I agree with you. There shouldn't be RSV in the hospital. The problem is that there is.
Well, at least not in the NICU.
In the NICU.
But I do want to say that this issue was discussed at length in the ACIP meetings without divulging any information. It was discussed, and we decided that was not the optimal appropriate use because there are other infection prevention strategies that can be utilized. And again, it's the same thing. We were at the time also trying to mimic, at least in part, what the palivizumab recommendations were, which was not to give it in the hospital. And we did not. When I first went to Columbus, we were giving it to our BPD unit, and that got stopped with the help of our pharmacists and our BPD people. So we are not giving it nirsevimab even in our BPD unit, and we have severe BPD still intubated at 8 to 9, 12 months of age.
Can I ask you, because I don't know if maybe some of you see these patients too, but we have some patients with pulmonary hypertension or hemodynamically unstable, heart disease that can't leave the hospital because they have to stay and depend on support until they get a heart transplant or a lung. What about them?
So we are not administering those either to those. I think that we are in a bit of a flux, and I will tell you that issue has come up even out in the community, including in my own hospital. But we are not recommending it at this point. Will that change? It may very well change. But I think at this point, we really want to focus on other preventive strategies.
We don't want to keep you here all night, and we've only got a few more minutes left, so I'm going to knock out a few OB questions here since I'm the representative for that specialty tonight. So would we expect women who get maternal immunization to have protection of their newborn for several months? The half-life of maternal antibodies, from what I remember from basic sciences, is about 6 weeks, so in the same range as the other things that we've talked about. So yes would be the short answer to that. If there's a delivery less than 2 weeks after the maternal dose, then you need to give nirsevimab. Are we agreed on that?
Yep.
Then there's a specific question about HIV, which of course is the prototypical immunocompromised state, and that's probably the most common thing in pregnancy. We can certainly give vaccine to those women, but we'd expect them to make less antibody, and it's probably not as well studied, so that might be a place where monoclonal antibodies have some advantage over maternal immunization. There's a question about the effectiveness or efficacy of maternal immunization. I think it's very similar. The New England Journal of Medicine using similar endpoints as far as severe disease from the New England Journal of Medicine article that was published. We don't have quite the same field data that we have that you heard about in Dr. Sanchez's talk. So here's a question I hadn't really ever thought of before, so this is a good question. Assuming that a child gets RSV despite prophylaxis, are we going to recommend a second dose in the next season?
Only if that child in the second season at 8 to 19 months of age have underlying risk factors, such as severe cystic fibrosis, such as bronchopulmonary dysplasia, or severely immunocompromised, or if they are native, or if they are living in endemic areas of Native American and Indian populations.
So the timer is flashing red, but I'm gonna listen. I'm gonna answer just 2 more OB questions, and we'll be
from the audience.
Finished. So, what is the timing for RSV vaccine in pregnant women? So the timing is to give it from 32 to 36 weeks when patients are pregnant from September to the end of January. That may vary, as you heard, because some of you might live in locales where that season is variable. RSV season is variable. The reason we did that is there were some concern about preterm deliveries in the clinical data that led to the approval of those vaccines, and so that's the way that they're given. I think that's also a little bit of a caveat towards giving a second dose of vaccine if somebody had received it last year, giving them a dose this year in a new pregnancy or the year after, and this actually has come up fairly recently at our own institution, so it'll probably come up for you as well.
Can I comment?
Sure. You can have the last word since you won the award today.
No, I just think that, the imbalance, which was not statistically significant with the pre-fusion vaccine, the Pfizer product, there was, and the FDA wanted post-marketing surveillance, and there was a recent study from 2 centers in New York that actually did not show any association with prematurity in women who had received the pre-F RSV vaccine, although there was higher cases of hypertensive disorders, and so that is still ongoing surveillance. But I think the prematurity is looking very, very reassuring.
Which is good for obstetricians and pediatricians. So maybe that's a good note to end on. So thank you for coming this evening, and I hope you enjoyed the presentation.
Thank you.